Well, good morning, everyone, or afternoon, depending on where you are. My name is Matt Whitaker. I'm the Director of Integrated Programs with Compassionate Choices, and it is my privilege and my pleasure to welcome you to the next in our series of webinars that we're doing right now as we all are spending more time in our own homes. We are inviting you into those homes to share with you some different knowledge and tools. So you might have joined us on Monday, or you might have joined us on Tuesday for those webinars. If you haven't, those are recorded on our website. This webinar too is being recorded right now, so please take note of that, and will be available in perpetuity. But today, as we celebrate National Healthcare Decisions Day, we are taking the opportunity to talk about our toolkit, the End of Life Decisions Guide and Toolkit. And as I mentioned, this is part of our Staying Stronger Together webinar series, which is featuring different topics every single week. If you're new to Compassionate Choices is a national nonprofit that is committed to empowering people and helping to expand our options that we have at the end of life. And as part of that, we believe it's so important on this day to make sure that we're engaged in these conversations about how to chart our own path towards the end of life and how to plan for that, how to speak about it with those who care for us, and ultimately how to ensure that we have an end of life experience that comports with the values with which we've lived. So we are so fortunate today as we step into this topic to be joined and led by Dr. David Grube, who is our National Medical Director with Compassionate Choices. Dr. Grube is a retired family physician with extensive experience around end-of-life care, but even more so, he's really a guiding light for us here at Compassionate Choices when it comes to all of these discussions. So we are so fortunate to have him and to be able to, again, in this very unique time as we're spending time at home, also be able to continue to engage in this work and to step into these conversations that many of us are feeling like are even more important than previously as we are in our current reality. So with that in mind, I invite you to get comfortable, to enjoy the next hour or so. Dr. Grube will do his presentation and we'll be taking questions from the question box. So if you see that on your Zoom browser and you have a question throughout the presentation, add it there, and at the end of the presentation, we'll make sure that we take as much time as we can to answer those questions and to attend to your needs. With that all in mind and that housekeeping taken care of, I'm going to turn it over to Dr. Grube to talk to us about end-of-life decisions. Thank you, Dr. Grube, for being with us.
Thank you very much, Matt. It's really my pleasure to be with you. I was asked about giving this presentation maybe 6 weeks ago, and I do have to admit, as you would understand, that what I prepared then and have historically given as a presentation has changed, not entirely, but quite drastically. So I'll try to address the topic that was originally asked of me, but put it in the context of our current pandemic, because I think it's important, even more important now than it ever has been, to make sure that your loved ones and your family know what your decisions are for your care, not just at end of life though, but at in any step along the way. And I want to put all that into context, as I mentioned, in our current reality. But before we do that, I too, like others in Compassionate Choices, want to take one moment to thank the healthcare workers and the first responders and everyone who is doing the things that need to be done, whether it's bringing food to our door or making masks. I want to honor them in a moment of quiet, and also to think about those who have been suffering from this disease, and also those who have died from this disease. It's a somber time, and it's an important time. This is a front page picture, an article from the San Jose Mercury News from yesterday. And it says that there is one conversation that doctors want you to have with them now, and that's the conversation about what your plans would be if you get sick. So now more than ever, advanced care planning, advanced healthcare planning is necessary and important. And still, as I understand, a minority of us as US citizens have had these conversations. There are pockets of wonder like Racine, Wisconsin, where 90% of people have expressed their advanced care plan wishes. But for the most part, it is not something that we have done in our country, the majority of us anyway. So I always like to show this slide because it talks about what I think matters. And I think stories matter. And Atul Gawande, in his such wonderful book, Being Mortal, reminded us that our story, each of us is a story, and he believes, and I agree, that the end chapter, the last chapter, matters a lot. And so that's kind of what we're talking about today. As Matt mentioned, I practiced family medicine in a little town in Oregon for over 35 years. And after I retired a couple of years ago, and I would see previous patients or friends, they would say, well, what do you miss the most about family medicine? And I would say, because it's true, that I miss the stories. I miss the stories that people brought every day, amazing things. And in this time of self-isolation and staying home, we are all kind of, I don't know all of us are, but many of us are getting into the corners, the dusty cobwebbed corners of our apartments and homes and finding things. And so I hope you'll humor me for a second as I put up this newspaper article that that's me, believe it or not, a long time ago, 30 years ago. But I was writing about this then because that was the year that the in 1991, the Patient Self-Determination Act was passed by Congress, which was the first time that the federal government codified the value and importance of an advanced care plan, advanced directive, living will, etc. And through the Patient Self-Determination Act, it became law that all facilities that receive federal funding needed to have a place for an advanced care plan in the medical record. I'll just bring one quote up out of that little article, which says, a friend of mine has a t-shirt. The t-shirt said, "Denial is not a river in Egypt." So I asked in that article, please decide what medical treatment possibilities you want for yourself and complete an advanced directive. Then hopefully the forms will never be used or necessary. So I dusted it off and I put it in my slide deck today, and I think it shows that this has been going on for some time and we still could do a better job. Now, before the 20th century, to be quite honest, healthcare was really palliative care. There wasn't anything that we doctors or nurses or healthcare team could much do for patients, particularly people that were near the end of life. And so we did palliative care. And as you can see in this painting, actually the doctor isn't even in the picture, but the priest is. And that was pretty much what end of life care was to try to assuage the suffering that the dying patients had because there was no cure. However, in the 20th century, health care became what we now know or call modern medicine. And while the priest is still in the picture, the doctor's at the bedside because actually there were things that she or he could do. There were antibiotics, there became all kinds of high-tech mechanical devices, imaging studies that we could do, wonderful treatments for scourges such as tuberculosis, and immunizations that would prevent such things as smallpox and measles. So we went from a palliative care situation to a cure situation. But as Atul Gawande said in this book, Being Mortal, which I hope you've all read, and if you have not, you have some time on your hands, you could read it now. We have changed the process of end of life to a medical process rather than a natural process. And we in the medical world haven't been very well prepared for it. Now, he wrote this book quite a number of years ago, but it could not be more timely in this quote than it is today. And so end of life care has become different. It's high tech, it's complicated. And sometimes this is what palliative care looks like in the 21st century. And as you can see in this poor, unfortunate person, he, I believe, is unable to probably speak for himself and share with his healthcare team what his wishes would be. And so that's why we're here, is because it's become very complicated to die in America. It's not necessarily a natural process anymore. And your healthcare team and your family need to know what you want when some major decisions need to be made. Because, as Dr. Gawande sort of summarized in his book, the default that we have as medical care providers in America is to do everything for everybody, every time. That's kind of what we think, so we won't get sued. And that makes it very, very complicated. However, the Patient Self-Determination Act declares that as an individual with autonomy, you, the patient, have options, and you may choose any of these options, not the last one. We'll talk about that for a brief moment. But you do not need to continue to have a medical team do everything for you every moment, all the time. You can continue to pursue treatments, and in the end of life, they may be prolonging and preventing your death. You can refuse treatment or partially have treatment. It's your right to have those choices. Hospice should be available for you. In most places in America, it is, and provides wonderful support in end-of-life care. It is your right in all states to decide that you do not want to have any nutrition anymore, and you can declare that. We'll talk about that more in length as the hour goes along. There is the option on in some situations for continuous deep sedation, which historically has had other names such as terminal sedation and palliative sedation. It is high tech and oftentimes in an institution, but that's where the medical team puts the dying person or suffering person asleep and kind of keeps them asleep. And then finally, in 9 jurisdictions and the District of Columbia, an adult who has volitionally, that means voluntarily, can ask their doctor if they have a mental capacity to do that and understand informed consent to receive a prescription that they could take at their choice at the time that they wish to end their life. So this is what we're talking about today. Each of these things is your choice. We're trying to make sure that you can be empowered to know that, but more importantly, that you can document that and you can have the conversation with your family about these choices. So where should we start about that? Well, it begins with yourself thinking about what your values are and what are your beliefs and what are the things that are important to you, what makes you happy. At the end of your life, if you could describe your very last day, what would it be like? Who would you want to be with you? What kind of music would you like? Even to the point of who would you not want to have there? What are some of the things that are important to you in regard to your abilities? If you're bedfast or unable to toilet yourself or care for yourself. Are those things that would impact your choices? Are there specific treatments, and we're going to talk about some specific treatments as the hour progresses, that you would want for sure, and are there some that you would not want? If that's the case, no one can know unless you have a conversation with them and explain them. And then, very importantly, what is your support network? And I understand that this is a big problem now because some of these support networks, there are barriers to have them exist when people get in the hospital and cannot have their loved ones or family or even their proxy, which we're going to talk about in a minute, come to be with them. So having these things written down becomes more and more important as things evolve, particularly in our current pandemic. A very important and sort of basic foundational book was written back in 2014 by the Institute of Medicine. It was called Dying in America. And it offered some effective approaches for making your plans and having the conversation. It was one of the books that sort of set off this whole now good group of books, including Being Mortal and particularly Finish Strong, that Barbara Coombs-Lee wrote, so that your wishes can be understood and they can be valued and they could happen. There are barriers, and of course the biggest barrier is not wanting to talk about this, not wanting to have the conversation. This was a problem in my family. My mother would always say, can't we talk about something more pleasant than what I would want at the end of my life? And it made it somewhat difficult for my father and my brothers and sister for us to help her near the end of her life because she didn't really want to talk about it. However, it's important to talk about these things, and there are ways and times to do them, and there are a lot of suggested resources for you, particularly in Barbara Coombs-Lee's book, but also in the Conversation Project, or The Conversation by Angela Valandez. And we don't necessarily always want to have the conversation end up just completing documents. The conversations and the discussions have so much value in and of themselves. They do give us guidelines so that choices can be made and we can get a sense about what our loved ones want or what we would want our loved ones to know. But the text that I referred to, Dying in America, spend a lot of time talking about the importance of the conversation and how palliative it is in and of itself. And the importance of the fact that this is a dynamic thing, these conversations and even the resulting documents or things that come out of it do not, they change, they can change. It's important to realize that, and we're going to talk about that too, about when are maybe the 5 times that you might want to revisit your plans and discuss these with your loved ones, and in particular your healthcare proxy. So having ongoing conversations and not keeping everything inside is so important to share what's important to you. There are so many benefits. I've just listed a couple here, and maybe the most important one is the third one down, but having these conversations and having your loved ones know what you want as you near the end of your life, what your values are and what your choices would be, is a gift to them. It's the ultimate gift of love, allowing them to do for you what you want. It may be hard for them. It may be not what they want for you. However, but if you can have these conversations, I've seen it again and again when I was in practice and we're taking care of people at the end of life. how important that was. We teach in our little community advanced care planning conversations and document completion in our health careers class in our high school. And we do it for a lot of reasons. One, because it's so educational, but also that these children can go home and model these things for their parents who might model them for their grandparents. So completing these things, having these conversations is ultimately important for you, but it's also important for all of your family and your loved one and your friends. And then there becomes less conflict as death approaches, not only for your family, but also for the healthcare team. Too many times in the ICU, the healthcare team has conflict because they've not understood what the individual wants. Now, the healthcare planning documents essentially are the living will and the healthcare proxy, which are combined in an advanced directive. And then there are some addenda that we'll talk about in a bit. And we'll also talk about the concept of the POLST, and particularly in the face of the current pandemic. So advanced healthcare planning documents combine the two pieces, the what and the who. They're different in state by state, and Compassion and Choices has a wonderful toolkit and website where you can go and you can click on the state where you live and determine what documents are able to be used in your state, because each state is different. For example, where I live in Oregon, a popular advanced care document called 5 Wishes is not honored in Oregon. So you need to look at your own state, and that's easy to do. You can just go onto the Compassion and Choices website, and you'll be able to find what the documents are that can be completed in your state. There is the what, and the what is if you have an event where you cannot speak for yourself and you or the healthcare team needs to know what you want, to declare what kinds of treatments that you would like to have be continued, and or what treatments you would not want to have, or how your loved ones could impact this, and if there's individuals in your family you don't want to make any healthcare decisions. All of these things can be laid out in the individual documents. And these are available in our toolkits, Compassion Choices, and I think they're very easy to understand and able to be completed. The who, it would be the person that speaks for you if you cannot speak for yourself. There's various names for this person. It could be your healthcare proxy or agent. There's a very legal name, the Durable Power of Attorney for Healthcare Decisions. That's a name not used too often because it's too legal. But your healthcare proxy, your healthcare representative, your healthcare agent will speak for you. And it should be one individual or an individual with a secondary individual if the first person is not available. Should not be a group. It has to be an adult, and it cannot be your healthcare provider. It would have to be someone else. And as I mentioned, you can determine if there's someone you do not want to speak for you. So here are the questions you need to think about when you're selecting your agent. Will they speak for you? And will they represent what your wishes are? Are they going to be available? Will they live close by or easily be able to travel? And of course, in this time of pandemics, that has changed. Do they know you well enough to know what you would want? Have you had these intimate conversations with them at length? Are they someone that you would trust with your life? But more importantly, are they someone that you would trust with your death? Are they able to talk about intimate and sensitive issues? Are they going to be here next year and the year after? Are they able to handle complicated situations if there's conflict? And are they able to be a strong advocate for you if there's disagreement with your healthcare team? Sometimes your doctor may not want to honor your wishes, and your proxy would need to be strong. We had this case in regards to my father-in-law. As he was dying a few years ago, his doctor would not honor his wishes, and it got to the point that we had to sort of intervene, and it was problematic. So having and I think it went better than it could have, because my wife and I, as his agent, were able to be strong and to disagree and to confront what we thought was inappropriate actions that were occurring near his death. This is a very long list, and I apologize for so much stuff on one slide. I think Matt has asked me never to do this, but I'm sorry, Matt, I put a lot of stuff on one slide. Anyway, these are all some of the kinds of things that your healthcare proxy would make on your behalf. Not only the choices of the medical tests and procedures and medicine options, antibiotics or not antibiotics, etc., but importantly, being put on breathing machines or not, getting treatments for kidney failure or not, having antibiotics or not. What about pain medications and the importance of adequate pain management, not only for pain, but also for respiratory distress. Large amounts of medication can help with difficulty breathing. And the list is long, but the point is your healthcare proxy has the right to make many, many decisions for you, even to the point of including Medicare and Medicaid decisions or other contract. The documents that you would complete, the advance directive, would need to be signed in almost all jurisdictions by 2 witnesses, and neither of them, the witnesses, can be your healthcare provider. In some states, and you have to look this up in your jurisdiction, a notary public needs to be involved, but in no states or jurisdictions does an attorney need to be involved. So these are, again, able to be uncovered when you look into the Compassion and Choices Toolkit on how to complete your advance directive in your state, and it's pretty easy to do. Where should you keep your advanced care documents? Well, you should keep the original and any working papers that are important, whether an addendum or other information, in a location that's easily uncoverable in your place of residence, and that your proxy and family members know where it is. This is a big problem. People complete their advance directive, they don't need it, and it kind of ends up going to places in our home that are dusty, and we forget where they are. The POLST, which I'm going to talk about more in a minute, is a more urgent document, and so it's generally kept out in the public somewhere, like on a refrigerator door. You want to make sure that your proxy, of course, has a copy of your document and all of your working papers. And then your doctor or nurse practitioner have a copy. Most all of these have a wallet card, so that you can put that in your wallet as well. I have suggested to my patients over the years to put one in the glove compartment of your car. Probably the most risky thing you do every day is get in your car and go somewhere. And so it'd be good to have it there. EMTs are taught to look in glove compartments for information. You can have a copy if you've been hospitalized or institutionalized. You can have a copy be placed in your medical record, and it's supposed to be the first page of a medical record in institutions. And then for individuals who may not have as good a support group, we can keep them in the church or the synagogue, and in some cases there are electronic registries. Particularly, I know in Oregon and other states we do have electronic registries for POLST forms. The language that's used in these should be specific and not general. Things like no heroic measures or I don't want to be a vegetable, that doesn't help anybody. The things that that matter to you and that you want or don't want should be specifically outlined. And when you're having the conversation with your healthcare proxy, living well is one of the phrases that we use, which means what matters in each day that you would like to have, and if that's accessible to you, and how that would be as in part of your document. We do have Compassion and Choices, some addenda for your healthcare document, and we'll talk about those in a minute. There are some things that are not an option, and this is one of them. Now, as I mentioned, these documents should be reviewed from time to time, and I got this this suggestion from, believe it or not, the website from the American Bar Association, and they talk about the 5 Ds. When you ought to review your health decision plan, when the start of each decade of your life would be one time, probably more frequently than that, but that might be a reminder for you. When someone in your family or is near to you has a death, that's a good time to review what your plans were. You may not remember what you said a few years ago. If there's been a major family change, such as a divorce, that might be a time to review what is in your advance directive and what you want to have your loved ones know. Certainly, if you have been diagnosed with a serious health condition, that may change everything that you've already previously put in there. And so I think that's another time to review this. And then finally, if there's been a deterioration in your overall health, specifically if it involves your inability to live independently, that's a very good time to review your advance directive. So maybe try to remember the 5 Ds. I thought that was a good suggestion. Your advance directive goes into effect when you lose your decisional capacity. And that means, what might mean loss of consciousness, it might mean intubation, it might mean dementia, it could be going into a coma from a disease, etc., or a car accident. But when you come out, if you then come out on the other side from, let's say it was a bad car accident and you lost consciousness, if you become mentally capable, you then can speak for yourself. Your advanced healthcare directive is not in effect. They don't, in particular, advanced directives are not of much value in an emergent situation unless they are easily uncoverable and able to be found. So if you're in a car accident or you have an event at home and the EMTs come, they're probably not going to be able to find your advance directive. So these are emergent situations, and so that's why it's so important that your loved ones and your health proxy know where your advance directive is and can get to them as quickly as possible. Decisions by healthcare agents are often honored even if they disagree with the instructions in a living will, and so that's why you need to choose your agent carefully. And of course, if there is conflict, it really makes it hard for the healthcare team to know exactly what to do, and so sometimes even in religiously affiliated facilities, it becomes a problem. And there was recently a court case in Oregon where this went on for a couple of years. So we're going to talk about in a minute how to make sure that how you can make sure your healthcare planning is honored, and some of the ways that you might be more likely to ensure it. But as I said, this is, and I put it in more bold font, advanced directives really aren't very valuable in an emergency unless you have them in your hand or your proxy is with you at that time. So what are some of the alternatives that we could have for that? There are forms, and these are available on the Compassion and Choices Toolkit sites for pre-hospital do not resuscitate forms, for portable orders for life-sustaining treatment, which is called POST, and medical alert bracelets or medallions can be another option. So let's talk for just a few minutes about cardiopulmonary resuscitation. This is an option as we near the end of life that I wanted to specifically address because there is a lot of confusion about it, particularly in the pandemic time, and some myths. I think you probably all know what CPR is. I just put it on the screen to remind myself to make sure that you know that it's when your heart has quit or you've quit breathing and others can come by and begin procedures which would try to make you survive. The procedures could be anywhere from doing heavy compressions on your chest, which is not always result in good things because ribs can be broken, etc. Breathing for you initially just can be done simply, but ultimately might be done when EMTs arrive with a tube that goes into your lungs. And sometimes now we have these AED devices, which are shocking devices, which can get your heart to be again beating again. But it's the CPR is usually done on everybody every time when they're found in quote down, which means not breathing or heart not beating, unless you have forms out like a POST form, or it's been ordered in a facility like a institution such as assisted living or nursing home or a hospital. It will be performed unless it's not indicated. And one of the things people don't understand, if you have a DNR form, such as in your advanced directive, and you get appendicitis, they will do resuscitation for you to get you through the surgery. So there are instances where you may have a DNR form completed where it is not valuable. But I think the most important thing to know is that CPR is not very successful, even in the hospital, if the individual, particularly if the individual has comorbidities, that means other kinds of conditions, like how old they are, how frail they are, if their kidneys are not working too well, if their lungs, if they have emphysema, or heart disease. And some of these statistics are sad and quite shocking. When we take polls about individuals in public about how CPR is effective, generally between 50 and 90% of people think that CPR works. In TV dramas, it works almost all the time. However, in reality, in the general population, even in hospitals, people who need CPR do only survive in a very small minority, somewhere between 2 and 17%. Will be able to be discharged from the hospital, and a much greater number of those people will have some loss of neurological function, such as not being able to think as clearly, or maybe they'll end up with a stroke or something else. If people have been in long-term care facilities and end up in a hospital and needing CPR, their success is again quite low. And even of the people who do make it out of the hospital after having had CPR, they will end up oftentimes having some other medical event in the near term. My point being that CPR is very important and it can help. and particularly in the young, and particularly if the stopping of the heart or the stopping of the breathing is witnessed. That's when CPR is of more value. Now, if you have written in your advance directive that you do not want to have CPR, and that's do not resuscitate, DNR, the EMTs have been instructed that they will not begin it, or they will not continue it if they've already started it. They will not push on your chest. They will not put a tube in your lungs. They won't monitor your heart rate or give you injections in your heart to bring your heart back to beating, or they will not put the electrical shocks on your chest, or certainly not put you on a ventilator. However, by foregoing DNR, that does not mean that the EMTs will not be kind to you and do good things to you, such as put some oxygen on for you, turn you, support you. If you're having some bleeding, they could stop that. They can give strong medications such as morphine and lorazepam, which is a medicine to stop anxiety, and certainly can get other healthcare providers involved in the event that you have chosen not to have DNR, such as hospice, which is so important in end-of-life care. There are these forms, and these are on the Compassion and Choices Toolkit websites, which we're going to show you in a minute. The main one that I really want to kind of spend time talking about is the POLST form. So these have many different names, but probably the most significant one is the POLST form. It's also called a MOLST, and I was looking at a website the other day that had like 20 different names for it, but what we're going to call it is the POLST form, which initially was physician's orders for life-sustaining treatment, but now it's changed because mid-level providers and physicians and advanced care registered nurses can complete these forms too. The difference between the POLST form and your Living Well or Advanced Directive is the POLST form is for the emergency. Now there are different, not all states have this now. There's no national registry or unification. It's coming. So again, you'll have to look at your own state to find out. And you can go onto the website of www.polst.org, and that will explain what is the form in your state. Usually they are a very brightly colored form so that they can be seen immediately when the EMTs or someone come into the facility. And they're useful for this kinds of groups of people. Anyone who's living in a facility like assisted living or nursing home or hospice house, or are frail, or people that have progressive diseases, if we would ask ourselves, is this person going to be alive in a year? And we would say to ourselves, well, probably not. That would be the person that should have a POLST form. And all the people that have terminal diseases, but anyone can have it. It's just that this is the group. Because this form is signed by a physician, and is available and should be able to be uncovered immediately on arrival of the emergency staff at the place of residence. This has to be honored. It's orders for the team. So different than advanced directive, this is for an emergency situation. Almost all POLST forms have these 4 components. The first one is CPR, yes or no. The second is initial treatment order. So you can pick generally 3 different groups. Would you like everything done after the CPR has begun? Or just a couple things like I wouldn't really, for example, yes, you can do CPR, but I don't want A, B, or, you can list those out. Or just things to keep me comfortable. I don't want to be breathed for I just want to have morphine or pain medication. The third section is for other orders and instructions, and the fourth one is for medically assisted nutrition or feeding. But I think the most important one, of course, is the first one, because if a person does not want resuscitation, the last three become moot. It's signed by the patient or the proxy, and it is signed by the doctor, or depending on the state, could be signed by the advanced care registered nurse, physician assistant, nurse practitioner, etc. Here's an example of one we have in Oregon. It would be in pink. I tried to get a pink one, but it was sort of out of focus. So in Oregon, they're pink. In other states, they may be bright neon green or other purple forms. But anyway, as you can see, if they're simple, they have the four components, then there's places for the signatures of yourself or your proxy and the signature from your healthcare provider. We have at Compassionate Choices a really wonderful section that you can, the website is there at the top. And this has, in the section called Plan Your Care in the Resource Center, we have these toolkits that allow you to figure out how to fill out these different kinds of forms and have the conversations with your family. Or if there's questions that your doctor might have, that your doctor could even call one of our doctors and get their questions answered. Again, I'm just putting up on the screen a couple of the web pages, but these are things that are so valuable for you, and I hope that you would take opportunity to look at them and see how they could help you. But this advanced planning guide, I think, is really, really a great one, a great resource. These are the table of contents in that guide, and they're very complete. And they, in much better detail than what I've shared with you today, will go over these topics about what matters to you, about putting your priorities down, about what life-sustaining measures you may or may not want, about choosing your healthcare proxy, putting all of this into practice, making sure your doctor or healthcare provider will honor your wishes, and then keeping the conversation going, most important. We do have some wonderful addendums and tools that can help. This is an excellent one that's new. It's our Dementia Values and Priorities tool. I would like to have you go look at this. You can learn a lot from this. It helps you discover and talk and think to yourself, and then just talk with your family about what matters to you and what your values and priorities are. Now, I would like to get specific in the last few minutes here and talk with you about the pandemic. This is an article that came out a couple days ago from northern Italy. As Dr. Pratt said on Monday, we don't know a lot yet. And these articles that are coming out on a daily basis in medical journals, and this is from the Journal of American Medical Association, are conflicting. They aren't. Each area, each country is different. But I think it's important for us to know what our options are and how effective they are. I want to begin by saying, as Dr. Pratt and others have said in these different webinars that we've had, that this virus, this COVID-19 virus, is a serious virus that impacts a lot of people, but most people, the vast majority of people, and we don't know, but maybe around 98% of people are just sick for a little while with it, anywhere from no symptoms at all. And some people have estimated that maybe 1 in 4 of us who have it don't even get sick. But many people might lose their smell, might lose their taste. They might have a bad cold. They may have a dry cough and be sick for a week, kind of like the flu, or not even. So that's the majority of people. But there, as you know from the news, when people get really sick from this, it's very lethal. And this article shows that. This is Dr. Graselli and his cohort group in several different hospitals in northern Italy. So this is not from the US, this is from Italy. But I wanted to bring this to our attention for several points. It was not a small group of patients. It was 1,564 or something. This is a typo here on the screen. It goes from February 20th to March 18th. As you can see, it wouldn't be April 18th. And they looked at this group of patients who were so sick they ended up in an ICU. That means the intensive care unit, where they needed some help. Most of this group were men, so the majority, and their median age was 63 years old. More than 2/3 of them had at least one comorbid condition. That means they had something else wrong with them, like high blood pressure, heart disease, lung disease, etc. 9 out of 10 of these 1,600 people needed to be put on a machine to breathe for them. And after 5 weeks, fully 58% were still on breathing machines in the ICU. 1 in 4 had died and 16% had been discharged. So when this virus makes us have such bad pneumonia, if you will, as Dr. Pratt described, fluid in our lungs, enough that you ended up in the hospital, it generally does not go well. It does not go well. And I think it does in a small group of people, as you can see, but this is really serious. So Compassionate Choices has come up with a wonderful toolkit for advanced care planning. This is a screenshot of that. And we've come up with fact sheets, and there are 4 very valuable fact sheets that I think are excellent for you to be able to go and read and learn about this advanced care planning, dying in the age of the pandemic, understanding what your options are, and using telehealth or telemedicine, which can be helpful. So here are the specific components of that COVID-19 advanced care planning addendum. And I'm not going to read them all to you, but they're practical questions. Do you want to go to the hospital, or would you prefer to try to get some respiratory care at home, and how could that happen? When you get to the hospital, do you want the healthcare providers to give you non-invasive options, or do you want to actually be put on a ventilator? I won't, as I mentioned, go through all the different questions, but I think it's very practical questions that you can ask yourself about, and it's quite complete, really, too. So this is in the website, as I mentioned. There's also another very good place to find information about how to complete your POLST in the age of COVID-19, and that would be at www.polst.org. And they have a lot of good information on that website, and I've just posted that to remind myself to remember to tell you. Well, to finish up, how can I ensure my healthcare wishes will be followed? Make sure that you understand that your advanced care plans are fluid, they're dynamic, they can change. Think about the 5 Ds and revisit them from time to time. Make sure that your agent is strong, it understands your wishes, will comply with your wishes when you can't speak for yourself, is available, and in this age of COVID, sometimes that availability may have to be through telecommunications, iPads and iPhones and computers. Use our website worksheets and our end-of-life decision guide so that you can understand how to think about your wishes and share them with your family. Make sure you discuss this with your physicians, your healthcare providers, and others, even with your friends, not only for yourself, but to get your friends to be able to outline and define their wishes as well. And if you have specific situations, use the addenda which there are several there. Now, a new way that I think is very valuable to make your wishes known is to video yourself on your device. When it's so much more powerful than a written piece of paper. If you have it on your device and it's uncoverable by your proxy, your agent, or your loved one, or yourself when you're going to a facility, if you can show them that this is what you want, and speak specifically, it makes a big difference. So this is becoming a more common situation now, and I think it's been a very valuable tool, particularly in the face of this pandemic. Well, Charlie Brown said, someday, Snoopy, we're all going to die. And Snoopy said, yes, but on all other days, we won't. So this is the day that we have. We are blessed to have this day. We are blessed to have all the things that we have. Many of us have wonderful resources, even though we may be bored and staying at home. But it's important to share our values and our wishes with our loved ones and with others, and to write that down. And this is the day to do it. This is our Health Decisions Day. And there's no real ending. It's just the place where you stop your story. So don't forget to go to our resource center. And a couple great resources are the book by Barbara Coombs-Lee, Finish Strong, and this is again my end-of-life decisions that you can get off the website. I'm going to leave this up on the screen because Matt's going to talk about this, but I guess it's time for questions now, and for me to quit talking. It's probably way past time for me to quit talking. So Matt.
Wonderful. Wonderful. Well, thank you, Dr. Group. Thanks for the care that you took in presenting that to us. And I've heard you give these talks before. Each time I learn something new and gain kind of a different tidbit of wisdom. So I'm so appreciative of you sharing that with all of us as we join in this together. Over 200 of us who are on this webinar right now. We do have time for a couple of questions, and I want to address one right off the bat, which is many of you have asked, can I get a copy of the presentation? So what we will do at Compassionate Choices is, along with the copy of a recording of today's webinar that you can share with your friends or your family, or you can view at a later date, we'll make sure we also include a PDF of the presentation so that you can take a look at all these slides, because again, they are full of really incredible information. One question that came in, Dr. Grube, was about your comment related to 5 wishes and why that might not be effective depending on the state that you're living in. Could you expand on that a little bit?
Well, the 5 wishes is a very popular one that many states honor, and so that you can look at it. I have looked at it, although not recently, because it's not honored in Oregon, and there are a few states where it's not honored. I don't know specifically why in Oregon it's not honored, but I think it's important to make sure as you read through any document that there are no restrictions in a document that would allow you, that wouldn't provide you with the ability to make any of the choices that I put on that option list. And particularly if you live in a state that authorizes medical aid in dying, for example, that you want to make sure that your document allows you to make any of the authorized choices that you have. Again, I don't know why Oregon specifically does not use the 5 wishes, but I know there are several other states that do not use it either.
Wonderful. And then just one last question, and then we'll talk about what's coming up in our webinar series. And that was, people heard your comment about a little town in Wisconsin where everybody talks about dying. And as we think about our planning for the end and ways that we engage with our community, could you share a little bit more about what's happened, for example, with Gunderson Health?
You probably should answer that question more than me. I know a bit about this, but they have taken this on as a focus and have done it and run with it. And I think the statistics are that it's over 90% now of people in that area have completed their advanced directive. They've been creative in all arenas to get people to complete their wishes. But Matt, I know that you know a lot about it as well.
Wonderful. Well, you know, it's an amazing little project that was engaged in by this healthcare system based in La Crosse, Wisconsin, called Gunderson Health, where they connected with their communities and they had conversations like the ones that we've been having over these webinars. And so while we all don't live in La Crosse, Wisconsin, we do have the opportunity to engage in these conversations and have had the ability to do so over this past week, and are going to continue to do so as we're all spending more time in our own homes, taking the opportunity to connect with one another across the country and to discuss these different pieces. So thank you, Dr. Grube, for today's webinar and for engaging and bringing us along in this topic. But we're going to continue to expand on these conversations with some more specific webinars. The first one that's coming up next is going to be on Monday, April 20th at 3 p.m. Eastern Time. And, you know, Dr. Grube talked about how so much of our planning around end of life centers around our personal values and how we're really charting our journey during our life. And so we're going to be joined by Diane Rehm, who many of you know is the inspirational NPR host who has done so much work around this topic and has spoke about this at length, for a workshop called Charting Your Personal Journey from Life to Death. So that's one that you're not going to want to miss. On Tuesday, Dr. Grube alluded to our new Dementia Values and Priorities tool and our new specific advanced care planning tools related to the potential of getting a dementia diagnosis. We're going to be allowing you to join a webinar that's being hosted by the American Society on Aging that features both Kim Callanan, our Chief Executive Officer, Tom Quash, our Chief Programs and Marketing Officer, as well as the CEO and founder of Us Against Alzheimer's and one of our dementia storytellers, Dan Winter, as they talk about these new tools, as well as things that are changing and coming about when it comes to dementia care and treatment across the country. And so that's going to be on Tuesday, April 21st at 2 p.m. All of our webinars we're doing our best to record and have available on our website moving forward so that you can access those and share those with your family members and folks who were not able to attend them. So if you're looking to either learn more about those, to register, or to view previous webinars, you can do that by going to the Compassion and Choices website, and under the Take Action tab, you can go to Staying Stronger Together, which is, again, our intention as we're in this interesting season. With that in mind, and as we close, I just want to thank everybody and express our gratitude for taking part in this online community and for being a part of the mission of Compassion and Choices and using this moment of trial and of uncertainty to connect and to deepen your understanding around these topics. Compassion and Choices sees this as a particularly important moment for us to be engaging in these conversations and to be connecting with one another. So as the world changes, our work does not stop. And so with that in mind, I want to remind everyone that Compassion and Choices, maybe you're new to the organization or maybe you're a sustaining supporter who we thank today, all of our work is dependent on the generosity of individuals who support this work. So if you are new to the organization, or if you're a supporter in today's offerings and the things that we've been doing as we've been working to stay stronger together are things that resonate with you, I would invite you to support us through a financial gift on our website at compassionandchoices.org, if that's something that you can do and that's meaningful, and if these offerings have brought meaning to you. It has certainly brought meaning to me to be able to connect with all of you, to express our gratitude to you, and to hopefully deepen your understanding around this issue. So with that, I will leave you all with gratitude and blessings. And as Dr. Grube said, we are surrounding all of you with our love and our support in this time, and thankful for each and every one of you. So with that in mind, we'll leave you to your day, and thank you for your participation.